Good morning. It's a little difficult to follow Ben, but I'm going to give it a try here for a few minutes. My name is Peter D'Souza. My wife, Mary Beth, and I joined Trinity a little over 2 years ago, and we've been blessed to have our two sons, Luke and Joel, baptized right here. I'm also an emergency physician on faculty at Stanford, where I work clinical shifts in our emergency department, a level 1 trauma center for both adult and pediatric trauma patients. Medicine has many different specialties, and when I entered medical school, I was almost certain I was going to be a pediatrician. As I progressed through my training, however, I was drawn to emergency medicine and the unique opportunity it affords to meet patients in a time of need. I spent a summer working with an emergency physician who did stroke research, and I had the opportunity to shadow him and learn more about the unique setting of the emergency department. As an emergency physician, I see the full spectrum of patients seeking emergency medical care, not just trauma patients, which is a small portion of what I see, but patients with chest pain, abdominal pain, cuts, broken bones, fevers, mental health emergencies, and patients with cancer or other chronic medical problems who have an acute problem seeking help. At the end of medical school, my decision to go into emergency medicine was more of an intellectual choice. I enjoyed the challenge of seeing an undifferentiated patient, gathering clues from the history and physical exam, selecting tests to work up a problem, and coming up with a working diagnosis. But as I reflect back on my career choice, I see that it may have been God calling me to work in this unique environment, to provide some relief to patients and family members on an otherwise stressful day. A patient in the emergency department is thrown into a very unfamiliar social situation. While patients may spend years or even decades forming a relationship with their primary care provider, a visit to an emergency physician is, for the most part, a chance encounter. The patients I see don't choose to come see me or choose to have a visit on a day when I'm working. But in a very short period of time, we form a relationship where people are very vulnerable, opening up and sharing details about personal medical conditions as well as their personal lives. I've been working in emergency medicine now for 15 years. At the start, especially during my training as a resident, my focus was on the medical aspects of the visit, making sure to consider the possible diagnoses, figuring out what tests to order and what medications to give. While these are all still very important, they are now more routine for me in my workflow. In recent years, I have come to realize that equally important is taking the time to connect with a patient and provide some comfort. Some visits are simple, and I can provide a fix to the problem, a laceration that needs stitches or a broken bone that needs a splint. But often the problem is complex. It could be cancer not responding to treatment that is causing complications that bring a patient to the emergency department. During these encounters, I try to remember that my job isn't to cure, but rather to provide comfort. I am reminded of a saying widely attributed to Maya Angelou, though the origins are hard to trace. It goes, "At the end of the day, people won't remember what you said or did, but they'll remember how you made them feel." As I've reflected back on what it means to be called, I realize I have been called at work to make people feel better during a challenging time, to relieve anxiety, provide empathy, and share in the emotions of the visit. In talking to Pastor Mary in preparation for today, I reflected a lot on a recent case I saw of a young woman in a bicycle accident. In terms of medical care, it was a pretty routine trauma patient. CT scan to look for bleeding in the brain or a broken neck, some x-rays to rule out fractures in the arm or leg, and some basic blood work. Fortunately, in this case, all of the scans were negative, and she was able to leave the emergency department that afternoon. I use the term routine here because this summary describes the medical aspects of hundreds of cases I've seen over the years. But I also recognize that nothing about that day or visit was routine for this young woman. She had recently moved to the area from the East Coast, and luckily her mother was visiting at the time from the Philadelphia area. When I heard her mother had arrived in the waiting room, I made it a priority to meet her as soon as possible to let her know that her daughter had arrived awake, alert, and talking, helping to relieve some of the anxiety and fear that she had from receiving a call that her daughter was brought to a trauma center by ambulance. After her imaging studies, her mom got to come back and be by her bedside. I got to speak to them both quite a bit during the visit. I was happy to later check in with them and let them know that no serious injuries were found on her scans. As I spent time preparing and stitching a cut on her face, I talked to them about our many visits to the Philadelphia area to visit Mary Beth's cousin, and about our love for Wawa sandwiches. Anyone who's been to Philadelphia or the New Jersey area knows what we're talking about there. We also talked about her college experience, her work in the Bay Area, and her training for a triathlon. These conversations helped bring some normalcy into an otherwise not normal day for the two of them. Becoming a father myself has made me even more aware of the needs of a parent of a patient in the emergency department, regardless of whether that patient is an infant, a child, or an adult. In reflecting on my work, I see that God has called me to provide comfort to patients and family on every shift by blending medical knowledge and skill with compassion and human connection. And I will remind myself of that before every shift as I ask myself, what can I do to make a patient's day better and provide comfort? Thank you.